Dear friends and colleagues, welcome to the 21st edition of the Pan-African Course on Interventional Cardiology, Pafcic 2020. I'm honored to kick off the program today, and I'm pleased and honored to co-chair this initial and first session of the program by having good friends and a very renowned cardiologist from Africa. I would start by Professor Salim Ben Khedda from Algeria. He's the Chief of Cardiology in Mustafa Hospital, Algiers. He's a very good supporter of Pafcic for many years, and we thank you very much, Dr. Salim, for being with us this morning. We have also with us Professor Abdallah Mahdawi. He's the past president of the Tunisian Society of Cardiology and Cardiovascular Surgery, and he's working in Sousse University Hospital. He is heading and leading a big cardiology congress for several years. Professor Sami Morali, Mohamed Sami Morali, he's the past president also of the Tunisian Society of Cardiology and Cardiovascular Surgery, and currently he's the chair of the cardiology department in La Rabta Hospital. Professor Khaldoun Ben Hamda, he's from Fatuma Belgib University Hospital, and he's very experienced interventional cardiologist, and we welcome him to be with us. Dr. Wathiq Takdamet from Algeria. Thank you very much for being with us, Dr. Wathiq. Dr. Qais Battikh, he's a co-director of Pafcic and very active and dynamic in all aspects of interventional cardiology, not only in Pafcic activities. And Professor Salim Boudish, he's from Mohamed Sami Morali team in La Rabta Hospital, also very active with Pafcic, and particularly in the preparation of Pafcic Online, which is the educational platform of Pafcic that will be launched very soon. I just, without any further delay, ask the first speaker to start. But before that, I would like to remind the speakers to just be on time and have their talks only in 10 minutes, so that we can have the opportunity of discussion and interaction with the participants. Another piece of information is the fact that Dr. Khaldoun Ben Hamda, he was designated the Q&A moderator. So Khaldoun, he will be looking at the chat and he will be selecting the relevant question to be asked to the panelists and to the speakers. So the first presentation will be given by Dr. Salim Boudish, and it's on complex left main PCI. Just to remind you that this session will be dedicated to learning from challenging cases, and it is in association with Africa Fellows Summit. So I hope we have a good number of fellows from Africa will be following this session, because they will learn a lot from it. Salim.
Micro, please.
Do you listen to me now?
Yes, Salim, we hear you very well.
Good morning.
We see your slides. You just put yourself on full screen.
Do you receive me?
Put your slides on full screen, please.
Is micro okay?
Yes.
Thank you. So, good morning, ladies and gentlemen. It is my honor to be associated to this 2020 virtual edition of Pafcic Congress in this inaugurating session dedicated to learning from challenging cases. So, with this presentation entitled "Complex Left Main PCI." Without delay, this was the clinical presentation. It was a 84-year-old female with hypertension. Clinical presentation was a very high risk non-STEMI. It was complicated by KLIP2 acute heart failure and TTE. Showed left ventricular dysfunction with 38% LVEF, with akinetic and thin inferior wall without significant valvular
Slim, do you hear
disease.
me? Slim?
Yes.
We cannot see your slides moving, so please put yourself in full screen. Plein écran, grand écran. Donc, you have to push the button on full screen so that we can see your slides, the whole.
And now?
Okay.
Do you receive slides now?
We see your first slide, you see it, but it's not in full screen. It's not in full screen.
Okay, I will.
Try to share your screen again.
Yes, I'm trying.
So to share your screen, you have, yes.
Do you receive?
We see your screen, but the presentation is not open yet. You have to open up your presentation first, and then you share the screen.
Okay, and now, is it okay?
Yes. Now, yes, exact. Click on that one. Now we have everything. Okay, you can move.
Sorry, yeah. So it was an 84-year-old female, as I said, with hypertension, with a very high-risk presentation of non-STEMI, complicated by KLIP2 acute heart failure. She had 38% LV ejection fraction with akinetic and thin inferior wall without significant valvular heart disease. So here was his coronary angiogram findings. So she had a CTO of mid-LCI. She had a complex distal lesion, which was a true bifurcation 1-1-1 of Medina, and as you can see, a full retrograde filling of the right, with also a tight stenosis, long tight stenosis of LCX to obtuse marginal. So this was the cranial view of the severe lesion, distal lesion of left main. This was another view of the distal lesion of the left main, showing particularly the tight stenosis of LCX ostium. This was the spider view. She had a very nice distal bed of LAD and obtuse marginal. So this, to summarize, this was so the anatomy of patient. She had a complex distal left main disease with true bifurcation 1-1-1 of Medina, long obtuse marginal stenosis, and CTO of RCA, which was very simple to cross with the G-CTO score of 0, without, so with tapered entry site. It was a very short occlusion. Distal bed was very nice, but unfortunately, MRI evaluation showed non-viable myocardium on this site. So we evaluated patient in medical surgical discussion. Mortality was very high. According Euroscore 2, it was of almost 8% and 15% according STS risk score. So decision of medical surgical team was to perform a left main PCI, obtuse marginal PCI, and medical treatment for non-viable CTO of the right. So our strategy was as follows: a 6F French radial access, stenting first of the obtuse marginal, two-stent technique for this complex left main PCI with T and protrusion technique, and we had bailout hemodynamic support, and in our cath lab only intra-aortic balloon pump was available. So this was injections with 6F extra backup 3.5. This was the spider view, this was the cranial view. And the first unexpected difficulty, as you will see, was really the wiring of the LCX ostium. So after 20 minutes of attempts with conventional techniques, tips and tricks, we tried polymeric jacket wire, we tried different bands for this wire, a double band curve, etc. So it wasn't possible to cross this LCX ostium. It was really an unexpected difficulty. So the only way to cross after 20 minutes of attempts was this advanced technique of reverse wiring of the side branch, as you can see, with advancing banded hairpin wire to the LAD, then to pull back and to reverse wire this LCX ostium. So this technique was described by this major paper of Burzotta in Euro Intervention 2010. So as you can see, this is the main figure for reverse wiring technique. So to advance this hairpin banded wire to the LAD, then to cross reversely the side branch ostium when we face really difficulties with conventional techniques. This technique was described originally by Kawasaki and all in this CCI paper in 2008. And this is the step-by-step technique. So we must disconnect the Y connector. We push a second wire. We do this hairpin band and the conventional distal band. So it is double band wire to push directly in the guiding catheter, then to reconnect the Y connector. So this was the technique performed in our case in this presentation. So it can be facilitated with dual lumen catheter, as you can see, such as Crusade or Sasuke from Asahi catheter. So you can advance easily the wire on the non-target vessel, then pull back, and then easily wire reversely the side branch. So second steps were stenting first this long lesion of the LCX to obtuse marginal by a 48 stent. This was the result. Then with the difficulty faced for wiring the side branch, we switched it from initial T and protrusion technique to really techniques more adapted when we have major concern regarding the side branch rewiring after main branch stenting. And the first technique recommended in this situation is really Dika crush technique, or also inverted main branch to side branch first stenting. So we adopted the Dika crush technique because of its high level of recommendation by consensus papers following this publication of Xiaoliang Shan in Jack in 2070s of Dika Crush 5, as you can see, with less significantly less target lesion failure with Dika Crush versus T-provisional or TAP-provisional stenting. This was due to less definite or probable stent thrombosis with Dika Crush in left main complex lesion, because, as you can see, gaps with T-stenting on ostium of LCX and also producing metal in the left main when T and production technique is adopted. So there was too much target vessel myocardial infarction with provisional T-stenting versus Dika Crush technique, which had more favorable outcomes. So we proceeded to first predilation of the LCX ostium with a non-compliant balloon. This was the result after predilation. So next we will see the Dika Crush steps technique. So firstly, we advanced the stent of the side branch. So it wasn't without difficulties. Then this was the positioning of the LCX stent ostium with smaller protrusion with near one strut or two struts protrusion on the left main. It was mini Dika Crush technique. This was stenting of the LCX ostium first. This was the first crush with non-compliant balloon. After pulling back the wire of the LCX, this was the angiographic control. Then, as you can see, this was the rewiring of the LCX ostium. In the proximal strut, so it is highly recommended to cross the proximal or the middle strut. This was the first two-step kissing. Then the positioning of the stent on the ostium of the left main in this LIO cranial view. So left main to LAD stenting. This was so the second crush with the left main to LAD stent. Then we performed a proximal optimization technique with 4.5 non-compliant balloon. This was the result after POT. And as you know, final kissing balloon is always recommended in this two-stent technique. So performance of recrossing was some difficult to the left circumflex. It is highly recommended to be in the proximal or mid-strut to avoid ostial gap when rewiring under the stent of the side branch. So you must be here or here at maximum. So after rewiring the left circumflex, we advanced two balloons. This was the left circumflex balloon. We performed a two-step kissing. This was the first step of final kissing. This was the second step of final kissing. This is highly recommended by Ormiston since 2008 because, as you can see, we perform a very more large side optimization when we do first the predilation of this ostium with high pressure, then second step kissing with normal pressure of 12 atmosphere in this two non-compliant balloons. So we achieve this very good view of the side branch when we proceed to this two-step kissing balloon. So this was the final angiographic result on the left main LAD and the left circumflex ostium. After pot, sorry, this is the final pot, and this was the final angiographic control in this very complex left main bifurcation true bifurcation lesions. So thank you for your attention.
Thank you very much, Selim, for this outstanding case, very complex, and I think you did manage to solve the issues of these patients, particularly with this left main, complex left main stenosis, but also about that side branch with the reverse wire technique, which is quite original. And I think it's very helpful. Before having the question maybe from the other panelist members, I just would like to ask you, do you think there is a particular kind of wires that you need to do to be able to do the reverse wire technique? It's not possible to do it with any wire.
So in the original papers, it is really recommended to use hydrophilic polymer jacket wires. In this specific situation, we used Whisper wire from Abbott, but any polymeric jacket wire is can solve the situation in this situation.
Okay.
And the hairpin band must be done at a distance of 3 centimeters or more. So after the radio opaque part of the distal tip of the wire. So 3-4 centimeters, we make the hairpin band, and we introduce it directly, this band, in the guiding catheter. So the wire must be first in the Y connector, then make the band, then introduce the wire directly in the guiding catheter. So this is the only way that this technique is possible. And dual lumen catheter, such as Crusade or Sasuke micro catheters, can really be of a great help in this situation.
Okay. Khaldoun, do you have any questions from the attendees?
No, for this moment, no, there is no questions. But I have a question for Selim. Selim, very good case, very challenging case. I'd like to ask you about the Deca crush technique. You need some learning curve, you need some number of cases per year. It's not a very easy technique. So I don't know, what's your experience about this?
We are more and more practicing Deca crush in our experience. It is a very interesting technique with very nice results in the original papers of Chen coming from China. So, and now Europeans were really skeptic regarding this technique, but now it is really adopted in consensus papers coming from European Bifurcation Club, Asian Bifurcation experts. So I think this technique should be learned and should be learning curve should be done in most of cath labs, because sometimes we have no choice. We must do cross techniques such as situation of dissection of side branch after predilation. So if we predilate the diagonal branch or the circumflex branch and we have dissection, we must stand this branch first. And in this situation, décalcroche technique is highly recommended. Really, mini décalcroche as we done, only 1 or 2 struts. It is high balloon consuming. We use really 4, 5, 6 balloons to do décalcroche. We must have all material available in cat lab, small balloons, extra support wires, hydrophilic polymer jacket wires to recross, and the final kissing balloon is mandatory in this situation. So I hope that it will be a technique more used in our cat labs. We are performing what recommend experts is to do five décalcroche to have the ability to perform it alone. So for multi-center trials with décalcroche, operators were asked to have at their experience at least five procedures done successfely with this technique.
Thank you. Okay.
I have 30 seconds to intervene. There is 2 important points, I think. The first one is the 2 steps for the kissing, the final kissing. I think it's it will be recommended. The second remark is the pot, the final pot. I think with 2 balloons of 3 or 3.5 millimeter of 3.5 diameter, I don't think that the pot with a balloon with 5 millimeter or more, we don't have more than 5 millimeter. I don't think that the pot must be done. I want to have your opinion about that, because after each procedure we have such discussion with Salim and all the team.
Okay, just one thought, because we have to move the program. I think it is what you have said, Salim, is absolutely right. Now there is a quite an agreement that décalcroche should be maybe the technique of choice, because conceptually and even clinically actually it provides a good immediate and midterm or maybe long-term outcome. But we have to recognize that this is a very sophisticated technique, and is certainly not the technique to be done by beginners. And also, it's probably not the best technique to be used in African countries where we have limited resources countries, because as you mentioned, it's very demanding in terms of equipment regarding balloons, the wires, of course. And so we have to keep that in mind. So when you have the ability and the experience and the material to do it, it's the way to go. But if you don't have all that, maybe it is better to go to a simpler technique. And one of the simplest one is the tap technique. It's very simple. And for beginners, I would recommend to start with the tap technique, and then if you are really experienced, then you can perform the décalcroche. I think for the sake of time, we have to move, because we have to end the session in 55 minutes, and we have 3 more sessions. So I would like to invite Dr. Wathik Tektemet from Algeria to give us a flavor on the management of STEMI in the COVID-19 era. We are all of us involved in these very difficult times now to take care of those patients. And we would like to learn from Dr. Tektemet regarding this particular environment.
Thank you very much, Mr. Chairman. It's always a great pleasure and with great interest that we participate in this event, which is Pafcic, Pan-African collaboration being one of our priorities. My communication today is more about challenging context than it is about challenging situations. In fact, COVID-19 has become a reality in the ground, which has not only changed the way that we organize this kind of meetings, but also our daily practice. So, first of all, do you have? Okay. Do we have the presentation in full screen? Okay.
Yes.
Okay, perfect. So first of all, first thing is quick overview of the situation in Algeria. As the rest of the world, we have experienced two major waves. Fortunately, our death rates is less than the rest of the world, maybe for ethnical reasons, but the real reasons remain to be discovered. What is the additional burden inflicted by this pandemic on our management on ACS? According to our experience, we can summarize this burden onto 5 major topics. The first one being the trend of primary PCI. We have experienced a decline of the number of patients treated for ACS, and this appears to be a global trend. For example, this German study, in which we can clearly see a break in the number of STEMIs received in both public and private facilities, and this drop is not its consequences. For example, this English study, which took a close look on out-of-hospital cardiac arrest, the same trend in STEMI received in ER, but at the cost of more out-of-hospital cardiac arrests. Maybe due to the patient's fear of contamination, but this is to be taken very seriously. Otherwise, the third major wave will be the one of poorly treated cardiovascular and neoplastic disease. This leads us to the second point, namely the organization of patient circuits. As far as we are concerned, we consider all STEMI to be positive. We therefore had to organize an isolated circuits for these patients. For 2 reasons. First, to avoid patient-to-patient contamination, but also to concentrate our effort to protect medical staff in a well-controlled circuits. According to the risk assessment of non-STEMI, screening is carried out before admission, otherwise patients join the STEMI circuits. And like this, we managed to reassure not only our patients, but also our medical staff. The third particularity of this context is the really high thrombotic burden of the lesion that we encountered. To illustrate my point, I will share with you 2 cases that we had to manage lately. The first one being about a male, 48 years old, with tobacco as risk factor, without clinical history, admitted for STEMI 3rd hour of the chest pain onset. The left network was without abnormalities. As you can see, we have a total occlusion of proximal right corona with a very high thrombotic burden. We didn't manage to restore the flow using thromboaspiration. And this is the best that we could obtain using an expert probe. So the operator decided to use a direct thromboaspiration using the guiding catheter. This is a less common technique, but really effective when it is about a proximal thrombotic load. This is the final result. In fact, we have a big thrombus, but with a TIMI3 flow. So the patient went under tirofiban, and a control angiography was scheduled during the index hospitalization. As you can see, this is the control angiography, no more thrombus, and we have a tight lesion in the proximal RCT treated with direct stenting with a good result. The second case is about a male, 65 years old, with tobacco as risk factor, admitted for STEMI age 6. This time we have a total LAD occlusion, We did manage to restore some flow using the guide wire, so we took the decision to direct stent. Unfortunately, this time the procedure was complicated by distal embolization. The common points between these two cases is the really high thrombotic burden. And both patients was diagnosed COVID-19 during their hospitalization. We retrieve this trend of thromboembolic complication in many series, mostly venous complication, but also ischemic, among which we can retrieve acute coronary syndromes. Another complication that we encounter during this context is the more occurrence of acute stent thrombosis. Our rate of acute stent thrombosis has tripled compared to the last year. A clinical case to illustrate: this is a woman aged 55 years with hypertension and diabetes as risk factors. And in her clinical history, we can find 2 sudden deaths in the family 1 week apart. She was admitted for the management of a high-risk non-STEMI. As you can see, we have a really simple, tight stenosis of LAD2, really accessible to PCI. So we took the decision to pre-dilate, then result. 30 minutes later, the patient experienced an acute chest pain with nasty elevation in practically all the leads. And as you can see, we have an acute stent thrombosis. So we managed to restore the flow using the guide wire. We decided to add some theophylline in coronary, but quickly the stent reoccluded. So we did decide to put a balloon into the stent. Why did we decide to put a balloon into the stent? For 2 reasons. Sorry. The first one being to treat a possible appointment of the stent. The second one is to try to crush the thrombus against the wall. Fortunately, we did manage to restore the flow. The patient went under tirofiban. She was diagnosed COVID-19 due to a high specific antibody levels, and we decided to control the patient during due to technical issues in our cath lab. We didn't manage to perform the control. There is many reasons to an acute stent thrombosis to occur. We can cite malapposition, distal dissection, and so on. But in this context of COVID-19, we think that this pandemic has something to do with it for many reasons. The well-known thromboembolic pathophysiology of the disease, but also the higher rate of this complication compared to the last year. Out of scientific honesty, we have to raise a third explanation: the desire of our team to reduce the procedural time, which may lead to stent malapposition. So we have to meditate on this. Last but not least, what is the role of thrombosis in this context? The opinions differ between authors. According to Mr. Zhang, primary PCI should be deferred and fibrinolysis should be selected for patients less than 12 hours. According to ACS, they provide a lower level indication for thrombolytic first approach. So the role of thrombolysis is yet to be defined. To summarize, SARS-CoV-2 infection is a thrombotic disease. Acute coronary syndrome associated with COVID-19 are most likely to have a high thrombotic load, less PCI success, more acute stent thrombosis, and according to our experience, the great importance of tirofiban in the management of this situation. So thank you for your attention.
Thank you very much, Dr. Met, for this very interesting presentation. Any question to Dr. Wathiq?
No, for this moment, for this moment, there is no question, but it's a very good presentation and all the fields were treated here. I'd like to ask you about, is there any increase of thrombus in the left ventricle in your experience?
Yes, indeed, there is an increase for left ventricular thrombosis, but the increase of all major thromboembolic complications, strokes, pulmonary embolism. So as I said, finally, SARS-CoV-2 is more thromboembolic disease than pulmonary disease. Maybe even that the pulmonary lesions are due to vascular lesion.
Yeah. Thank you. For this moment, there is no question. Qais, if you have a question or a comment about this.
Yes, I have a question for Dr. Wathiq. Thank you for this nice cases shared. I want to ask you about the use of the 2B3A. Do you recommend now to use it at the first line, not use it in the bailout, in this special case of patient with COVID-19?
To be really honest, I cannot give information. Our experience, it is a really effective approach. So we practically always use tirofiban in presence of high thrombotic loads, especially when it's COVID-19 patients. And it's really effective. In our control angiography, we always have good results. Some reocclusion, to be honest, but the major part of patients evolve well.
Just
I have a question about your antithrombotic regimen after primary PCI. We know that it is recommended to stop heparin after successful PCI in this setting. I don't know in the COVID era if you stop heparin, because we have seen more stent thrombosis, more acute stent thrombosis in this setting. So, do you continue heparin infusion for which duration, and which Y2 P12 inhibitor do you prefer in this COVID setting? Do you have access to ticagrelor, prasugrel as an alternative to clopidogrel in Algeria?
It's a very good question. Practice, we do stop the heparin therapy only if we put the patient under tirofiban. We must not forget that the patient is COVID-19. The heparin is used not only for the cardiac issues, but also for the thromboembolic complication of COVID-19. So we maintain heparin therapy for as long as it is necessary for the COVID-19 to resolve. This is the first point. The second one being that we have access to ticagrelor, but to be honest, it is not really accessible to everyone. So the medication that we always use practically is clopidogrel. For now, we don't have a lot of late, generally speaking, a lot of late stent thrombosis, but it is more interesting, effectively, to use ticagrelor, which begin to be available in my country.
Just another remark. It's about the using of NACU, association with NACU for such patient. I think there is some papers who are was edited in this sense. What's your opinion about that? Because you said that it's a recommendation to continue anticoagulation for 14 days the Tunisian guidelines, but I think it's the same or more in Algeria. What's your opinion about such association?
I totally agree with you. NACO being a magic treatment, which is really effective in many situations. In my country, the heparinotherapy can be prolonged until 30 days, months. So it can be a really alternative to use NACO. Unfortunately, this medication is not yet reimbursed in my country, and this limits a lot the use of it for our patients. But this can be a really good alternative for heparinotherapy. I have just a small remark regarding pulmonary embolism. We don't have data, but we have this experience that pulmonary embolism occurs 21 days and later. So practically all the pulmonary embolism that we received occurred 3 weeks later. So this is why sometimes when the D-dimers are high, we maintain the heparinotherapy even until a month, maybe later, if there is a thromboembolic complication like ventricular thrombosis or diagnosed embolie pulmonale.
Okay, thank you very much. That was very interesting. I would like now to welcome Dr. Roland Guetta from Abidjan, Côte d'Ivoire. He's a good friend for many years, and we are really happy to have him with us today to give us a presentation entitled Unexpected Hemodynamic Instability During PCI. Welcome, Roland.
Thank you, Habib. Good morning, ladies and gentlemen. Thank you, Mr. President and Moderator. Before my talk, I would like to thank the Pafcic Scientific Committee and particularly the chairman of this course, my friend Habib, for the invitation to join this challenging case session. So I try to share my screen. So can I see my screen?
Yes, we see it.
Okay, thank you. So I have to talk about hemodynamic instability during PCI. So it's about 52 years old patient with diabetes. We have present on STEMI 1 week later. The echocardiography show left ventricular dysfunction with anterior hypokinesia. The coronary angiography performed 1 week later by radial right axis in the good start hemodynamic condition. So the coronary show a complex lesion of the C-complex, a complex bifurcation lesion on the C-complex, and a lesion on LEDA, the proximal part of LEDA and the middle part of LEDA. This lesion of LEDA can be evaluated by FFR, but we don't have FFR in our cath lab. The right coronary artery of this patient is normal, as it shows on this slide. So you decide to treat according to the clinical context and the echocardiographic lesion. You decide to start the percutaneous treatment by LED angioplasty. So at the beginning of this angioplasty, this is the image of the start of the angioplasty. Donc you use a guiding catheter, 3.5 GL guiding catheter. So at the beginning of this angioplasty, this angioplasty is marked by a proximal LED dissection. the patient experienced an acute chest pain with sweat, with an hemodynamic instability. This is a potential life-threatening complication of PCI in the management, and the management of this situation is a real challenge in our practice. According to the definition of, and the classification of coronary dissection, our case is a type F dissection with a total occlusion. Many different mechanisms can explain this occurrence of this type of dissection. Faced to this challenging case, the purpose is to find the true, to find us absolutely the true alignment of the coronary artery. We can be helped by high performance guide wire and intracoronary imaging, but these tools are not available in our cath lab. So, intracoronary imaging devices are not available in our cath lab. So, you use an Azai cyan blue guide wire to reach the true lumen of LED. You use a second guide wire to try to find another way and be sure that the first wire was in the right lumen. You use an Ephora 1.5 millimeter balloon at the very low pressure to try to reopen the LED. The result was a tiny two flow, confirming that the first wire was in the right lumen. We put a stent on the middle part of LED and a second stent one on the proximal part covering the dissection. The final result is good with a better hemodynamic situation of our patient. Intracoronary imaging device, particularly OCT, are useful tools of the management of this case, but it is not always available in many cath labs in sub-Saharan Africa. To finish, I want to share with you this whole message. First, perforation and dissection are the main cause of hemodynamic instability during PCI. Intracoronary imaging can be useful in the management of this case. Limited technical support to manage with serious situation. There is a limited technical support to manage this situation in sub-Saharan Africa. Efficient use of available resource is the usual. Thank you for your attention.
Thank you very much, Roland, for this very nice case, and certainly stressful, and something that you don't like to see every day. But you did manage it nicely, and your presentation is open for discussion. Any question or comments to Roland?
Oh, for this moment, there is no question. So I'd like to congratulate Dr. Roland for this nightmare case. I don't know if one of us need to have one of these cases. It's a very, very, very challenging case. Congratulations. Your patient is alive.
Yes, alive. Thank you.
Yes.
Go ahead, Khaldoun.
Yes. So I'd like to ask you only one thing. If you have this kind of situation, you use your intra-balloon pump or another support or something like this. And what about heparin and anticoagulant in this situation?
Okay, thank you for your question. So I don't use intra-balloon pressure for this situation. But for heparin, you start the angioplasty with heparin, 3,000 and 6,000 unity of heparin to start the angioplasty.
Okay. It's a very good case.
I don't think that the intra-aortic balloon can resolve the problem in emergency. I think if it fall to restitute a flu in the
right lumen, the right.
The flu, I think it will can serve, but I don't think in emergency that can help to resolve the problem. It's a mechanical problem. I think it's a problem of angioplasty.
Oui, Salim.
Thank you, Dr. Ngueta, for this very nice presentation and management of this serious complication. So I have one trick to share with you in this situation. If we want to be sure that our wire is in the right lumen distally. So in the Africa cath labs, I don't think that microcatheter are available. So one tip is to take a small balloon, to make a perforation of the balloon, of this balloon, then to put this balloon distally to the occlusion, to the site occlusion, and inject through the hub of the small balloon. So this can be assimilated to a microcatheter. If we don't have OTW, if you don't have a microcatheter, you can use a standard balloon, perforate it and inject through this balloon to be sure that you are on the right lumen. So this is a small tip to that can be very helpful in this really serious complication.
Tunisian microcatheter.
Thank you for your support. Yes.
Roland, may I ask you, do you have cardiac surgery on site in your hospital?
Yes, we have. Yes, we have.
Okay, because one of the questions, and it didn't happen to us in our experience, but I just would like to ask you, did that happen at any time that you had to send patient to surgery just because you were not able to cross? And any experience with that? Because it shouldn't be an easy task also for the surgeon to take care of these kind of patients.
Yes.
Any experience, any case?
No, I have any experience to drive the patient to surgeon. No, you have some patient. We have some this situation. You have to this situation in the cath lab. Any patient go to surgery.
Okay, Pafcic.
I have a more simplest approach in front of dissection, especially in our countries. We don't always have the necessary materials. What we have to do is simply to try to navigate in the small arteries after the dissection. If it is a re-entry, if you navigate into the small vessels past the dissection, you can, I think, stand without worrying about it. This is the technique used in total occlusion after all. So in the moment that you can navigate into small vessels, I think it is not dangerous to put a stent.
Yes.
I mean, one tip. I mean, in our experience, that we have never had a case where we were not actually able to cross. And one thing that we have learned is that don't push too much material, balloon, for example, to cross. This is a mistake. So you have to navigate through that dissection to go into the true lumen, but don't. And you have again, as it was mentioned by Roland, you just need to be calm to take your time, and ultimately you will be able to cross it. One of the question is what kind of wire you should use. In our experience, hydrophilic wire, although they go everywhere, you know that they very quite easily to false lumen. Those wires were actually helpful to find the right path and go into the true lumen. Okay, so if you don't have any further question, thank you very much, Roland. It's my pleasure and honor to welcome my good friend, Professor Samir Stoot. He's the former president of the Moroccan Society of Cardiology and very experienced international cardiologist, and he will be presenting to us a case on PCI in a high bleeding risk patient. So welcome, Samir. You have to unmute yourself. You have to unmute yourself because you're muted.
Thank you. Thank you, Habib. Thank you. Hello, everyone. Do you see me? Do you see my screen?
Yes, we do. We see it. Just put yourself in full screen, Samir, please.
It's always a pleasure to talk to you, and I'm very thankful for the invitation, Professor Gamra and the Pafcic committee. And as you know, my presentation is about management of percutaneous intervention in high bleeding risk patient. You know that coronary angioplasty in high bleeding patients remain very complicated because the fragile balance between bleeding and thrombosis. And when we have atrial fibrillation and ischemic disease, it's the most dangerous combination. And we must deal about the use of dual or triple antithrombotic therapy. And I finished my presentation by the guideline, the last guideline and future perspective on high bleeding risk patient. It's a clinical case of 83-year-old woman that suffered by chronic hypertension and with a history of external hemorrhoids. She suffered by paroxystic AF since 2010 and new oral anticoagulation. And in September 2019, palpitation crisis revealed non-STEMI troponin positive. The TTA revealed left atrial slightly dilated with a good EF. EKG is a sinusal rhythm with the anterosuperior block, hemiblock. And this patient was treated with clopidogrel, rivaroxaban 20, and aspirin 75. We use a radial coronarography to see two vessel lesion, and we did angioplasty with 2 stent onyx on the LAD and circumflex. This is the lesion of the proximal LAD. There is a lesion on the proximal circ. The right coronary was good. The angioplasty was simple with onyx 275 24 on the LAD. Lesion of the circ, the proximal circ, angioplasty of the proximal circ. and the final result on the circ and the LAD. And the improvement was favorable after angioplasty, and the patient discharge treatment was rivaroxaban, clopidogrel, and aspirin. 1 week after, she suffered by moderate rectorrhea, and we needed electrocoagulation and switched to apixaban. We stopped the aspirin and used dual therapy with apixaban 5 twice and clopidogrel for 6 months. And the evolution was favorable with neither ischemic nor hemorrhagic event. And we see in this case how it's difficult to do a PCI in this type of patient of high bleeding risk, because we must balance between stent thrombosis and stroke, and use 2 or 3 anticoagulant that can be very delayed for the patient. And one of the most interesting slide is this slide when we see 2 phases on acute syndrome risk, when the first month's thrombotic risk is more important than bleeding risk. That's why we must very securize the first months. And after the first months, bleeding risk is more than thrombotic risk, and we can do less antithrombotic after 1 month. And for choosing our patient, we have a score recommended by European Society of Cardiology, that precise depth score that we use on the time of the angioplasty, or the score depth we use after 1 year of angioplasty. The item is about hemoglobin anemia without white blood count, age, clearance, creatinine clearance, prior bleeding, and when the score is more than 25, we do a short depth. If inferior to 25, we do a standard depth. For the depth score after 12 months after the angioplasty, there is another item. It's important. There is the age, there is the diabetes, there is the type of the stent. It's important, like a paclitaxel stent, or the diameter of the stent is very important. There is another score. It's RRC HBR. It's a consensus, academic research consensus. It's a score. It's very simple to use it. It's an application. And here we list all the high bleeding risk patient, and the main is the age over than 75, use OAC planned before PCI, person with a cancer, person with creatinine clearance inferior for 40 millimeter, any prior intracerebral bleed or any stroke, and other. And this person is not rare. There is 30% candidate to PCI are high bleeding risk patient, and major bleeding after PCI is multiplied by 4 in short or long-term mortality. And that's why the management of HBR patient remains controversial, and there is a lot of parameters that we must use to deal with this patient. There is the duration of antiplatelet therapy. There is the association of anticoagulant. There's the type of the stent. It's important. The decision on PCI or KBG, the vascular access is very important, and the radial access is one of the best. The prevention of gastrointestinal hemorrhage, bleeding, and on the stent studies, the first stent randomized study to evaluate efficacy and security of short depth 1 month with the polymer-free DES versus BMS was leader-free, and she revealed superior clinical efficacy of DES versus BMS with the 50% reduction revascularization risk, and the security of DES with the 29% MACE reduction, including stent thrombosis. Another study is the senior trial that compares synergy with REBIR, BMS, and the result was the same, that MACE are more interesting with the synergy on favor synergy versus REBIR, and safety is more interesting with the synergy. The latest study is Onyx 1 global study that compare Resolute Onyx with Biofreedom with 1 month depth, and the superior acute was very interesting with the Resolute Onyx versus Biofreedom, and the primary safety endpoint, cardiac death, myocardial infarction, and what at 1 year was the same on the two stents. And now we present you the latest recommendation of the different European and American society on HBR use of the anticoagulation. And we see here in HBR, in the American, for BMS, we do only 1 month, for the US 3 months, and in the European 3 months for BMS and 1 month for DS. On the acute coronary syndrome with PCR in patient with HBR, you see here that in very high bleeding patient, we can use only 1 month aspirin clopidogrel and continue with clopidogrel. In high bleeding risk, we can use for 3 months. On STEMI, it's the same. It's 6 months aspirin ticagrelor or aspirin clopidogrel. What about the PCI and AF in HBR? You know that patients are in America or Europe more than 1 to 2 million patients who are with atrial fibrillation and take anticoagulant, and the mortality is huge. The difference between no AFA and AFA. The patient with oral anticoagulation indication was paroxystic, persistent, or permanent AF with such VASC 2 superior or equal to 2 score, mechanic protetic valve, deep venous thrombosis, and pulmonary embolism. A lot of studies are in the field that compare double or 3 anticoagulation, and the first was the West study after Pioneer, Redwell, Augustus, and Trust, and the West study was the study that we see that we can use double therapy with less bleeding, and the safety is the same. The pioneer AF with rivaroxaban reduced composite endpoint bleeding event with rivaroxaban based regimen, dual or triple therapy versus vitamin K3 therapy. Redual with dabigatran has the same result with non-inferiority between warfarin triple therapy and dabigatran dual therapy, and the event was the same. And that's why in the European Society of Cardiology concern high bleeding patient, we use at the time from the initiation clopidogrel and oral anticoagulation only, dual therapy for 12 months. The North American expert consensus for high bleeding risk is triple therapy for the first week, and after double therapy up to 6 months, and after 6 months we use single anticoagulant. And I want to have like a take-home message that development of new generation of DES allows us to deal with this type of patient. Vascular access is the radial preferred. Gastrointestinal protection is important. Clopidogrel is more recommended in this type of patient. In chronic coronary syndrome, who has PCI in HbA, we use 1 to 3 months DAPT, then long-term single therapy. In acute coronary syndrome, it's 1 to 3 months DAPT for non-STEMI and 6 months DAPT for STEMI, then long-term single therapy. And for the atrial fibrillation and PCI in HbA, novel anticoagulation and 1 antiplatelet for 6 months, then 1 new anticoagulation for a long time. Thank you for attention.
Thank you very much, Samir, for this very interesting presentation, up to date and tackling a very important issue that we manage on a daily basis. Are there questions to Professor Samir Stout?
Thank you, Samir. Maybe.
I want to ask a question.
Sammy, we cannot hear you very well. Can you get closer to the microphone, please, and speak a little bit louder, please?
It's okay now?
Yes, it's better.
My question is, in all that recommendation, I think the complexity of angioplasty, the complexity of I will speak or use one French word is the complexity of montage of stents. Do you think that in these recommendations there is no place? Because in practice, when we treat 3 or 4 vessels in the same time, when the left main is concerned, or if we do a CTO and we put 2 stents or sometimes 3 stents, I think that we lose comment dire, la pertinence, la pertinence of such recommendation. What's your opinion, and what do you do in practice? The second remarks is that the place of the free polymer donc stands in this recommendation. I think that all the manufacturing of stents don't have a heavy proof to introduce it in recommendation, or is the problem of the cost and the possibility of to use it in many places in the world?
Yes, Morad. For the first question, I think always in the recommendation they speak about high bleeding patient, but there is high ischemic patient, and that's the difficulty when there is the two and the two effective. It's like main trunk or left main, or a lot of stenting, and there is equilibrium that we must do when we have the two situation: high bleeding and high ischemic, I think that in high bleeding and high ischemic, the patient, the first months, it's important the first months that we must do tree therapy, like some recommendation in the American expert, not consensus. It's important to judge a bit between the two situations. For the second question, I think that a free polymer is interesting. It was a leader free that discovered this important situation, but with the latest Onyx global study, they demonstrated that it's the same like biofreedom, and it's very interesting because the latest stent have the capacity to deal with the free polymer stent. I think another studies can affirm or confirm this.
Salim?
Okay. Thank you, Samir. I don't know if we can ask another question.
Yes, please, you can start, and then Salim has asked also, he raised his hand. So, Qais, you have a question?
So, especially in old patient, do you think that we have to reduce to use the low dose NOACs associated with that, or probably even with the simple antiplatelet therapy? I think in this patient, the case that you presented was a high risk patient, and we use rivaroxaban 20 milligram and apixaban 5 milligram bidaily. Maybe in this patient, I don't know if there is a recommendation to reduce the dose of NOACs to do with 50 milligram or 2.5 milligram bidaily in this case when using that association, especially in old patient. What do you think about this?
I think the studies demonstrate that we can use the 15 milligram of rivaroxaban for the use, and we can use the dabigatran at 110 for this patient. You have right. I think there is two projects that the studies demonstrate that for rivaroxaban and dabigatran.
All right. Okay.
Habib, Professor Habib. Professor Habib Jamra, I'd like to ask you some questions. I receive actually the questions. So we have Jamel Langer, our president of the GTCA group. He asked about the presentation of Dr. Roland. He tell him, what if you cannot reach the true lumen? It's the first question. And another question about do you reduce the dose of rivaroxaban, apixaban, dabigatran when you associate DAPT? This question is from Qais Batir. If one of the speakers can answer these two questions, it will be good.
Okay, Samir, I think you can ask the first question. The second was answered already.
Do you reduce the dose of rivaroxaban?
Yes. For dabigatran and rivaroxaban, we can reduce to 15 for rivaroxaban and 110 for the dabigatran.
Okay, thank you. And for Dr. Roland from Jamel Langer, what if you cannot reach the true lumen? You have a large dissection, and what if you cannot reach the true lumen? I think cabbage or something like that. I don't know. If you have a response for this, Dr. Roland. You are with us, Dr. Roland? Or
yes, yes. Thank you for the question.
Yes.
Yes, it's a big challenge if you can reach the right lumen.
Yes.
I think the surgery is an option, but it's also a challenge for the surgeon because the hemodynamic instability in this situation is not easy to manage this lesion. So I think intracoronary imaging can be useful to manage this situation. But if you can't reach the right lumen, really it's very difficult to have a good evolution for this patient.
All right, last question, Salim. Short question. You have to unmute yourself because you're on mute.
Hello.
Okay.
I had the chance to recently traduce the new ESC guidelines 2020 on non-elevated ST segment myocardial infarction, and there is very detailed guidelines to HBR patients. These guidelines, the most important innovation is the introduction of the ARC-HBR classification, as said Dr. Stott. So ARC-HBR classification was established in 2019 in circulation and was adopted by ESC in the recent guidelines. This classification put patients in high risk when there is one major or two minor criteria for bleeding. And if patient is aged more than 75 years old, it is sufficient to be in HBR classified. So your patient in this clinical case was really in a very high risk of bleeding. And as said Dr. Murali, there is a balance between ischemic and hemorrhagic risk in these guidelines. And there is a very well established criteria for ischemic risk. This is left main, CTU, more than 60 millimeter stenting, two-stent bifurcation technique. Donc, this is a very well established criteria for ischemic risk and very well established criteria for hemorrhagic risk as established by ARC-HBR classification. So these recent guidelines recommend to reduce the NOAC dose to lower dose such as rivaroxaban 15 milligram, apixaban 5 BID, and dabigatran 110 milligram per day in association with DAPT. So we must use the lower dose when we have HBR patient. It is recommended. And finally, my last commentary is these guidelines reduce to 1 week the triple antitherapeutic association. Antithrombotic association. So 1 week, only 1 week, aspirin, clopidogrel, and anticoagulant. Then 1 month of dual antithrombotic therapy, clopidogrel and anticoagulant. And after 1 month, we keep only the anticoagulation after 1 month in HBR patients. So this is a very reduced time for association. 1 week for triple therapy, 1 month for double therapy, and then anticoagulation only. And just I have one answer to ask. I don't know if in the panelists, do you have this is in mind? What do you think about LAC, the left atrial appendage closure, to avoid anticoagulation and really very, very HBR patients in this situation? Is it possible to use left atrial appendage closure to avoid anticoagulant in very highly risk patient needing anti-aggregate therapy?
Samir, I think we're running out of time. Samir, if you have a short answer. My answer is yes, of course. If the patient is eligible for the technique, yes, that's a good way to go, to do it, yes. And then you avoid many of these pharmacologic association and combination, and then you can reduce the risk of bleeding. Yes, I would like to thank you, Samir. One word.
I agree, but there is a situation that it's impossible, like non-STEMI or STEMI, to use this before the angioplasty. This is if chronic coronary syndrome, and there is, I think, it's not the situation, the acute situation.
Exactly, definitely. Okay, thank you very much. I think we have learned a lot from these 4 challenging cases in adult setting. We have learned about left main, complex left main with very difficult access to side branch. And then we have learned about STEMI management in the COVID-19 environment with Dr. Ratiq's presentation, hemodynamic instability related to coronary dissection that was not easy to manage by Roland and Geta. And we finished the 4th case was on HBR, high bleeding risk patients management with PCI by Dr. Professor Samir Stood. Thank you very much for having shared with us this session, for having taken the time for this. And we need to leave the room for our pediatric cardiology colleagues who will be presenting challenging cases, but in pediatric patients. And I hope you can join too, because we have a lot to learn from those patients. Thank you very much.
Thank you.
Thank you. Thank you very much.
Bye.
Thank you all.
Bye.
Bye. Thank you
Bye.
for sharing. Thank you.
Bye.